What causes shortness of breath? What causes shortness of breath? It's a very common problem, shortness of breath. This is Dr. Jamie Koufman, and this is Dr. Koufman's Acid Reflux Hour. As most of you know, my specialty is respiratory reflux, or acid reflux that affects the respiratory tract. And so I feel eminently qualified to talk about shortness of breath. The reason is that acid reflux can either be the cause of the shortness of breath, or the trigger for the shortness of breath, or even a masquerader. So let's begin with the really common ones. And the really common ones are asthma, I guess COPD, chronic obstructive pulmonary disease, which includes emphysema, and all the other basically chronic diseases, as well, and triggered by smoking, for example. So let's just talk first about asthma. Asthma is a major disease in the United States. We spend $80 billion a year treating it. Over the course of my career, which spans, as you know, decades, I've been asking people who had asthma circled on their intake form, say, when you have an asthma attack, do you have more trouble breathing in or out? 4 out of 5 go in. And so I want to begin by expressing some concern about this, because asthma is exclusively swelling within the lungs, within the bronchial tubes, and difficulty getting air out. It's a prolonged expiratory wheeze. So anything else is not asthma. And breathing in, very few things you can say never. Trouble breathing in is never asthma. Now, people can have both, trouble breathing in and breathing out, but it's not necessarily asthma. So that's the first thing I want to just say, that every physician in the country, and all of you should know, that trouble breathing in is usually reflux, and trouble breathing out is asthma. Now, that said, there's data from a friend of mine, Sue Harding at the University of Alabama in Birmingham, that says, by the way, what are the triggers of asthma? 77% are triggered by reflux in her data. So that means that not only is asthma a real thing, but it's not just allergens that trigger it, but reflux, and perhaps reflux most of the time. So now we've got reflux causing asthma, and we've got reflux causing trouble breathing in. So when people say they have shortness of breath, and I'm actually doing a consultation, after I've determined that you have more trouble breathing in, I ask, do you have more trouble breathing in, out, or both? And most people go in. So there are different types. First is exercise, exertion. You run up 2 flights of stairs and you're huffing and puffing much more than you should. So exercise on exertion. The second type is have trouble moving air in or out, or both, which of course is asthma, trouble getting air out. So trouble getting air in, that shortness of breath is caused by a few things. First, it can be caused by something called laryngospasm. And these are frightening attacks in which the vocal cords clamp shut when there's a reflux episode, I guess presumably to prevent the what's going up from going down into the lung from the aspirating. And it sounds like this. And that's inspiratory stridor, noisy breathing on the inhale. And that usually lasts seconds to minutes. It can be broken by sniffing. If you can sniff, this is a mechanism by which there's an automatic sniffing causes the vocal cords to fly open. So this is a reflex. So the second thing that can occur is something called paradoxical vocal fold movement. And what that means is the vocal cords are clamping partially shut, not clamping then, closing shut during the inhalation. And it's called paradoxical vocal fold movement because they're supposed to open when you inhale. And this takes weeks, months, or can even perhaps go for years. The most common cause of this is, again, respiratory reflux. The next type of problem is trouble getting air in or out. We've discussed asthma, and we've discussed, by the way, asthma, laryngospasm, and paradoxical vocal fold movement are called reactive airway diseases. Matter of fact, so is allergy. When you get an allergy and you sneeze and you have a runny nose, those are reactions to things. But what if you have something blocking your airway? It could be a narrowing called subglottic stenosis, or narrowing of the airway below the vocal cords caused by reflux. This data we provided in the 90s, almost all. We were treating subglottic stenosis with a laser and it kept coming back. And then we figured out, wait, if these people have their reflux treated, we can fix them. So subglottic stenosis is a real problem, not something you see every day. But there are other problems, and they can be some of them big problems like obstruction of the trachea and subglottis from a cancer of the thyroid. Some of them can be related to other types of tumors, benign and malignant. So things that block up the airway consistently, or worse than consistently, progressively over time, those you need to go see an otolaryngologist, an ear, nose, and throat, and have an examination with an instrument that goes in the nose and can evaluate the upper airway, and that needs to be done. By the way, this is not a common cause of a shortness of breath. So now we're going to talk about Koufman syndrome, or Koufman sign. I ask, trouble with exertion, trouble getting air in and out, or do you have trouble or difficulty or discomfort taking a full breath in? And the vast majority of patients who have shortness of breath say that. Now, they may have more than one. Some people say I have a shortness of breath on exertion, but I also have that one where I can't take a full breath in. So I've now spent 40 years doing reflux testing, diagnosing and treating people, and I can tell you difficulty taking a full breath in or discomfort with that is almost exclusively, I'm saying almost exclusively because I can't prove it. All right, it's exclusively related to respiratory reflux. And it's not because there's something wrong with the lung. It has to be vagally mediated. You remember the vagus nerve, if you read my articles on vagus nerve, they control everything. They control the respiratory system, they control the digestive system and the cardiovascular system. So we don't know the exact mechanism, but if you have trouble taking a full breath in fully, you have respiratory reflux. Now, let's talk about chronic obstructive lung disease. It tends to be progressive. I've written a blog on it, which is very interesting. It's about an older man who came to see me. He had oxygen. He was carrying it with him. And he had trouble wheeling himself from the waiting room into my office. And I asked him, he stopped smoking 25 years ago, and yet the disease was progressive. So we evaluated him for reflux. He had reflux testing, ambulatory double probe, pharyngeal and esophageal pH monitoring, and it was grossly abnormal. So we put him on a program, a really tight program. He was really willing. And within months, he was no longer using oxygen. His disease had stabilized, perhaps improved some, and he was on his way driving to Florida to see spring training for his, I can't remember his favorite baseball team. So there was a dramatic turnaround in COPD in a patient who had quit smoking 25 years ago and yet still had progression of disease. And by the way, 25-year-olds don't have COPD. They show on TV some woman waking up in the middle of the night coughing. She's young and thin and beautiful. And they say, if you wake up in the middle of the night coughing like this, you have COPD. And the answer is, no, you don't. You have reflux. So without going further, there are lung diseases. For example, cystic fibrosis is a lung disease. And if you have reflux and cystic fibrosis, your prognosis is very poor. So reflux is silent, it's nighttime, and it's a major player in shortness of breath. And in my opinion, it can affect any and all. So it's the cause of laryngospasm. It's the cause of paradoxical vocal fold movement. It's the cause of subglottic stenosis. It's the cause of inability to take a full breath in. And it's a contributing factor for everything else. It can trigger asthma and so on. So understand that silent nocturnal respiratory reflux is called that because most people don't wake up in the middle of the night with symptoms, and they don't have heartburn and indigestion during the day, so it's silent reflux. Shortness of breath affects, I've gotten some data, I'm beginning to keep it. Shortness of breath, at least the people who consult me, patients, have 43% have shortness of breath. Of that group, 54% have a shortness of breath on exertion. There were 8 of this is a small series who had difficulty breathing in or out, but 7 were in and 1 was out, so there was only 1 asthmatic. By the way, if we got this right, we could save $60 billion a year on the misdiagnosis of asthma and put that money towards a diagnosis and treatment of respiratory reflux. And actually, very surprising, 77% of people that said they had reflux and shortness of breath had difficulty taking a full breath in. So I think that's an important, new, and there's a word in medicine called pathognomonic, and it's actually a great word. It means that this sign means you got that disease. There's not another option. This is the sign. This is pathognomonic. So difficulty to take a full breath in or discomfort doing that is pathognomonic of respiratory reflux. That means if you have it, you have it. Now, I have a lot of questions today. I know I've not done a complete, we could talk further about shortness of breath, but I think the essence for people who have reflux is here. Now, if you go back to any of my blogs that have many of my posts that have the reflux symptom index, go ahead and answer those questions. And if you have a score of 15 or more, the chances are better than 90% that you have respiratory reflux. So I have a lot of interesting questions today, and some of them are provocative, and some of them bring up other topics. For example, the first one. Now, it says, can sarcoiditis cause respiratory reflux? Is there a link between the two? And the answer is yes. Sarcoiditis causes xerostomia, and xerostomia is a fancy word for dry mouth. Turns out saliva is really important in preventing reflux, because we all have reflux events after we eat. But when we swallow bicarbonate, and the bicarbonate in the saliva will neutralize acid within the esophagus or wherever it goes, and with each swallow, the pH or the acidity comes back to normal, to not pH, to not acidic. So that's called esophageal acid clearance. Anyone who has xerostomia, okay, and radiation will do it. Everyone who has radiation of the head and neck has xerostomia and has reflux. We've done a study, it's a small study, 26 patients, 100% of them have reflux. And so you can add to that Sjogren's syndrome, which I've written about, which is an autoimmune disease that attacks the salivary glands. And now you can add sarcoidosis. Now, if you have xerostomia, you need to sleep in a bed that's elevated. You need to end your meals early. You need to be drinking alkaline water. And you need to be taking basically most of the elements of my detox diet. And the detox diet is presented as a post in January of this year. So you need to be long-term fighting this, because you are the candidate to get esophageal cancer or something else bad over the years. It won't happen in 1 year, but it certainly can happen in 10 or 20. So sarcoid joins the list of xerostomia, dry mouth, not enough saliva, conditions that cause or contribute severely to a reflux disease. Now, this question is so confusing that I'm going to go through it. So it begins, is this a lifelong battle? And the answer is yes. It is a lifelong battle. Reflux is not a medical condition. It's about diet and lifestyle. So this question is, how long will it take to breathe normal again? And the answer is when your reflux is gone. And if your reflux is gone, you'll know when it's gone. You're still having breathing problems. You need to be evaluated by an ENT. Is surgery the only option? Surgery is not an option at all. I keep telling the story of my patient from the Upper East Side. Lovely lady, had surgery by the best surgeon that I know 5 years ago, and she consulted me recently with shortness of breath, coughing. I couldn't manage at all. And I said to her, what time do you eat? She said 8 o'clock. I said, what time do you go to bed? She said 10 o'clock. And I said, you reflux all night, every night. So even a rebuilt valve can become stiff and swollen and non-functional, even though it's a big old hunk of good tissue. From once the reflux gets started, the more you reflux, the more inflammation, the less effective the valve is, or the rebuilt one. So surgery is not even an option. So if you're eating late, if you're stopping at McDonald's, if you drink soda, if your diet is poor, if you're eating too late, if you're drinking alcohol, you need to go back to square one and take a look at the detox program. Now it says to get off medicine to be able to breathe forever is, again, how do you get off medicine? Well, I don't recommend PPIs at all. So when you're well, what I recommend, you're going to be taking 1 in the morning, 1 before dinner, and 2 before bed. So that's 80 milligrams of famotidine or 800 milligrams of cimetidine, Tagamet. So you start, and the first one you stop is the one before dinner, then the one before breakfast, and then one of the ones before bed. And you do this, I would do it a month at a time, because you don't know if it's important or not for sure. If you can go 4 months tapering and then off, you don't need it. If you taper off medication, still keep it with you. Ooh, I'm going out later than I'd like. Take 1 before you have dinner. When you get home, take 2. And go ahead and take the Gaviscon and sleep up higher. So if you have a risk night, evening, whatever, then go ahead and treat that night. But even that's even after you've tapered off medicine. This question goes on and on. Tagamet versus famotidine, constipation, anxiety, gut motility, effectiveness. The H2 antagonists are, in my opinion, the safest and best tolerated effective medicine in America, period. So the constipation, anxiety, gut motility, and effectiveness are not consequences of these medicines, in my experience. Now, mind you, I've only treated about 50,000 people with it. So the next one could have, but constipation, anxiety, gut motility, and effectiveness are not something or complications we see with the H2 antagonists. That's Tagamet, cimetidine, or Pepcid, famotidine. I always recommend the generic. The person is asking this complex multi-part question. I can go one further. There's a question down below that says, my doctor said that they lose effectiveness over time, the H2 antagonists. And in fact, in my long-term patients who stay on medication, I recommend that they flip-flop and they switch every year. So if you're on famotidine, you go to cimetidine, and a year later you go back to famotidine. And that little difference seems to make a difference, so you don't have as much what's called tachyphylaxis, or getting used to it. There's not a lot of getting used to it. In pregnant women, we treat them for 9 months. We talk about safety with little fetuses, and they do just fine. We've been doing this treatment, and same I'm recommending to you, in pregnant women for the better part of 25 years. There are a couple of questions about Globus. My throat is tight with a lump sensation and sticky saliva. What would cause this? Now, the first thing I need to say to you is, I've written about all of it almost. So, if you went into my blog, sign up, JamieKoufman.com, put your email in there. Each week you'll get an email telling you the topic. Interested, open it. Not interested, delete it. Globus means a sensation of a lump in the throat. We've actually studied this for the better part of 30 years and actually never really ever reported it. I went into private practice and I lost the ability to mine data, but I can tell you that the sequence of progression of reflux is the lower valve gets stiff and swollen and you reflux more. Esophagus usually gets a little lazy, and finally the upper valve kicks out. And when the upper valve kicks out, it can do several things. It can have high pressure. We've seen pressure as high as 300 millimeters of mercury. If you've ever had your blood pressure taken, by the time you get to 200 millimeters of mercury, your arm hurts. So very high, and we've seen high rebound pressures where it's normal during the swallow, and then it goes sky high. We've seen other types of abnormal pressure patterns, including premature closure of the valve during the swallow, and this causes difficulty swallowing. This doesn't go through. So globus indysphagia, there's an article on globus, is caused by reflux, and it's one of the first symptoms to go away. The question is, do you need to have a diagnostic test? And what I recommend, if you really feel you need it, get your reflux treated. Do it. It's yours. It's in the ballpark, your ballpark. There's a barium swallow esophagram. Barium, you stick, you drink it, and they look at it as it happens, and it should be done upright, standing, and supine, lying down. And that'll tell the whole story. Usually there'll be what's called a cricopharyngeal bar, meaning you see that this is too tight. It never should have surgery. Let me say it again. Treatment for this is never surgery, ever. Now it's different if it's a Zenker's diverticulum, which we're not going to talk about today. I can't give you a number, but I think globus occurs in a small number. I think it's about 10% of our patients. And I actually have to ask first, the thing in your throat, is it mucus? Is it a sense of a lump in the throat? Is there something down there? Is it both? And often it's both. And so here comes the key question. There's a key question. There's a pathognomonic key question. For someone who's driving them crazy, I got a lump in my throat, I don't know what to do, it's awful, I can't deal with it. And you say to them, you have it all the time? They go, yeah. I said, how about when you're actually eating? Do you notice when you're actually eating? And they said, nope. Diagnostic of upper esophageal sphincter misbehaving from reflux. We used to, in globus patients, get follow-up, and the answer is there's a thing called manometry, where you actually measure these pressures, but nobody does it. GIs don't look here very carefully. They're only interested in the esophagus. So to my knowledge, no one is doing a pharyngeal manometry pressure measurement anymore. But we used to get a follow-up manometry, so we'd see the abnormal pattern, the premature closure, the difference from normal pressures and all that. And we wait a few months, we get a repeat study, they were all normal. So we never get a follow-up anymore. So besides the barium swallow, theoretically, someone who has a high-definition manometry system, we used to look at the esophagus first and then pull it back and look at the throat and the valve area, and that's how we got this data. But globus is a manifestation of reflux. It's generally one of the first to go away if you've got effective treatment. And if there's any question whether there's something else, something growing, a tumor, or anything else, then the barium swallow esophagram or the ENT examination, or both, should be diagnostic. You all don't need to run and get a bunch of CT scans or MRIs, in my opinion. This is really becoming an increasingly common question, which really sort of validates the concept that respiratory reflux is any and all parts of the respiratory system. How do I get rid of pepsin in the nose and ear? Okay, so pepsin in the nose can cause nasal obstruction. It's often worse in the morning. If you look on my most recent post on alkaline water, you'll see that there's a little spray bottle. Yeah, it's this one. And the advantage of this is when you swallow water, alkaline water, you don't get any on your vocal cords. Let's say you're doing 8 shows a week on Broadway. I can spray my vocal cords directly, wash out Pepsin. pH 9 water, that's all it is. Pepsin dies at pH 8. This same company, if you go and you buy these, you put the same name, I can't remember, Cobalt Blue 2-ounce bottle, makes Strompers. So you get up in the morning, before you get out of the bed, you squirt that in your nose, and you just wait. And there's another little pearl. If it burns when you put it in, you got terrible reflux. Okay, because the burning will go away. It's just water, and you got Pepsin, a lot of Pepsin. I don't know why it burns, but it does. Now, there is no question. The question is, how long do I do these things? And the answer is that if you look at my detox program, it's doing a whole lot of things all at the same time. And so the question of getting rid of Pepsin in the nose and the ear goes back to basic anatomy. I just want to point this out. If you read the article on ear, you'll see that in the pharynx, there is literally a place where a pond could occur. And the ponding or puddling place happens to be right where the eustachian tubes are. And the eustachian tubes are what give you equal pressure in the ears, so you hear them click when you swallow. And so people have pressure problems in their ears, hearing loss, ear pain, and sometimes tinnitus can be caused by this, can be caused by reflux. So those are the people that need to be sleeping on a high incline and follow a pretty rigorous program, I would say, for more than a month, and then don't shut down, meaning I was on a program, now I'm back to normal. You're going to have to figure out which variables are most important to you. If alkaline water kills Pepsin, would it be effective to gargle with it to prevent Pepsin from migrating up? Yeah, it would. You can use Pepsin nose drops, Pepsin spray. I think the Pepsin spray probably does as well as gargling, but I don't know that. But I see no harm in gargling with water. pH 9.5, alkaline water, unless it's made by Coca-Cola and or other companies and has phosphates, has no side effects of any kind. There's no such thing as a water side effect. I've already addressed famotidine becomes less effective over time. Famotidine, cimetidine every year. And this one gets back to a question that I really can't answer, but I can tell you the probable answer. And that is, if you're on a detox program, can you use a protein powder? And the answer is, I don't know. If you have to mix it up, if you can mix it up with alkaline water or alkaline or milk, or I don't know, almond milk, then you're much more likely to not have something acidic. But if you just mix it with regular water, it may be acidic. So this is a pH paper. Again, my last blog on a post on alkaline water has a pH paper. You can click on it. It's the right one. If I'm getting sore throat from reflux, is it too late to go on the reflux protocol, or is this the start of cancer? The answer is no. Cancer doesn't cause pain until you're dead. It's huge and it's over. And so get an ENT to examine your throat and get on a reflux protocol. I have another shortness of breath question. I had it mild for years and recently become more severe and consistent. Do you think it's a result of my hiatal hernia worsening? Hiatal hernias have nothing to do with reflux, really. Okay, most of us have them. Unless it's greater than 6 centimeters, it doesn't mean anything. You have reflux. You have respiratory reflux, and your respiratory reflux is out of control. People think there's one thing. I have a question here. Well, does alkaline water ever cure anybody's reflux? And the answer is by itself, no. Does sleeping on an incline by itself? No. So the whole idea of a detox program is that you're already fallen in the abyss and that you need to have an intense program designed to stop the reflux 100% over a period of time so things heal. And I think it's a metaphor all the time. If I bang my thumb on the hammer and it's all stiff and swollen, at the end of a month it's fine. Were I to bang it every night, or 6 nights a week, or 2 nights a week, it would never be fine. And so stopping the reflux for a month is a detox program. And there are many parts to it, including alkaline water spray, gum chewing, a low-acid, low-fat diet, sleeping on an incline, eating really early, and so on. So that's the starting point for most of you, is a real detox program. And another question about hiatal hernia. Go on my blog and just type in hiatal hernia in the box and you'll see an article. And what it basically says is, normally the esophageal valve is right at the diaphragm. If it slips up a little bit, you see a little hiatal hernia. But we know that people with hernias can have no reflux, and people with no reflux can have hernias. So the hiatal hernia is not a game breaker at all. Can I put serum water drops in my eyes on a regular basis? Fine, it's water. Because my eyes sting throughout the night from reflux. I don't really know the answer, but it's water and you can put it in your eyes. Getting close to the end. Time-wise, I'm over a little bit. So I'm just going to finish with this. Is there a point when being on this medication can cause harm? And the answer is, I have patients who've been taking ACE2 antagonists, famotidine, and Gaviscon, advanced aniseed, and in some cases with neurogenic symptoms, gabapentin, and neurogenic symptoms for decades. I had a woman call me from Saudi Arabia that I saw in 2015 asking me, do I still need to be on all this medicine? So let's call us a day. I think all the questions today were very good. But I urge you to use the blog as a resource. Okay, when you have questions, and it's not always just right. Sometimes you don't get the quite answer, so retype the question again, and hopefully you'll get to the right post that'll give you answers. But I've written this blog predominantly to get what I know in the public domain, and actually predominantly, first and foremost, for people who are doing consultations, because a consultation is only 30 minutes. Anyway, I wish you all well, and see you next time.